the pulmonary vessels are seen separately from the opacities. There is no evidence of soft tissue opacity in bilateral paratracheal or aortopulmonary regions. The lung fields appear normal, both cardiophrenic angles appear normal, and the visualized bones and soft tissue appear normal. So, based on these findings, my differential diagnosis would be sarcoidosis. The next differential I would like to keep would be lymphoma. However, I would expect asymmetrical hilar enlargement in lymphoma.
Any
The
specific laboratory test to suggest sarcoidosis?
the lobulated pattern of
Laboratory
hilar
test.
enlargement. A
Laboratory test.
laboratory test, serum angiotensin converting enzyme
Okay, AC.
levels,
Okay,
ACE
AC.
levels.
Yes, okay, good. What are the stages of sarcoidosis on plain radiograph?
On plain radiograph, stage 1 is only bilateral hilar enlargement. 2 is pulmonary parenchymal changes. 3 is combined, and 4th is end stage pulmonary fibrosis.
Excellent, yeah, boss. Okay, here is combined with some fibrotic changes. Okay, this is a good differential also. Eggshell calcification. What are the possible causes?
Eggshell calcification.
Silicosis.
Sorry? Okay, continue. Continue.
Yeah. Eggshell calcification is commonly seen in sarcoidosis, silicosis, treated lymphoma, amyloidosis.
Excellent, yes, excellent. Okay, last case. What do you
I'm
see?
presented with the frontal chest radiograph of a skeletally mature patient. I can see enlarged, smooth lobular opacities in both hilar regions. I can see the hilar vessels as seen separately from these opacities. There is also
Are you sure? Are you sure it's separate?
No, I can see there is convergence of the hilar vessels towards the opacity. There is also widening of the carinal angle.
Yes.
And I can see there is enlargement of the cardiac shadow
Let's
as
correlate
well
all
with
together.
increase
Okay.
in the so based on these findings, I would my most likely diagnosis is pulmonary arterial hypertension. I will
Suppose, oh, very good. Suppose this is a CT of the same patient, but actually it's a pronasal case, but just assumption. What are the findings?
There is a dilatation of the pulmonary trunk and right and left pulmonary arteries. There is also dilatation of the right atrium and right ventricle with the straightening of the interventricular septum.
What you are looking for else in this CT scan?
I would like to look for any filling defects in the pulmonary vessels to rule out any pulmonary thromboembolism. Then I would like to look for features of right heart failure with increase in right heart pressure and changes of reflux in the liver.
But,
And I
what
would like
are
to look
the okay? So the final diagnosis what? Final
uh,
diagnosis?
is pulmonary arterial hypertension with
What are the
right heart strain.
good etiologies? Common etiologies.
Most commonly it is idiopathic. Otherwise, it can be due to chronic thromboembolism, can be due to underlying pulmonary parenchymal diseases. Uh,
And also cardiac.
okay, cardiac.
Like shunting. So it's a vascular pulmonary etiology, it's a cardiac like shunting, and it's a pulmonary lung etiology. Okay, cardiac, vascular, pulmonary. Very good, yeah, boss. Very good. Next candidate. Anyone? I think we finished the list. Anyone want to share?
I can present.
Okay, boss. Proceed.
I'm presented with the frontal chest radiograph of a skeletally mature female patient. I can see a large mass that is overlying the right hilum with a well-defined lateral margin,
Good.
with the irregular lateral margin. And the medial margin is merging with that of the mediastinum. The hilar vessels are seen through this mass, suggesting that it is not in contact with the hilum. I cannot see the margin of the ascending aorta through this lesion, suggesting that it would be in contact with the anterior mediastinum. and the underlying ribs appear normal. There's no calcification or any fat density within this lesion. I'm looking at the rest of the lungs for any other findings. I cannot see any other relevant findings in pertaining to lungs or the pleura or the skeletal system. So in summary, I think this would be an anterior mediastinal mass with anterior mediastinal mass that is projected over the right hilar shadow. My possibilities would be in an adult patient would be a thymoma. And secondly, it could also be a teratoma.
Just a differential of anterior mediastinal mass. Yes, correct,
Right.
correct. Anterior mediastinal mass. So unilateral hilar enlargement may be related to anterior mediastinal mass. Okay, and also may be related to. Can you comment?
So in this
Another case.
cardiomegaly that is seen, and
Yes.
the left hilum appears bulky and irregular. Also, I see that there are some reticular opacities that are radiating from this hilum into the rest of the lung parenchyma. I would be looking for any cause. I'm basically suspecting that this could be due to lymphangitis carcinomatosis. I would be looking for any lesion that could explain this finding. I can see that there is some heterogeneity, some ill-defined sclerosis seen in the right humeral head. This could be a lesion here. If I had a radiograph to see this better, I would be able to comment more on that aspect.
Actually, it's a case of central bronchogenic carcinoma because of this speculated margin seen on lateral lesion. So bilateral hilar enlargement, two main differential diagnoses, sarcoidosis and others. Others like what? Pulmonary, arterial, and arterial hypertension. Okay, lesser differential diagnosis or other differential diagnosis of lymph node enlargement, lymphoma, and tuberculosis. Another list of differential, stay with me, my friend, reticular pattern with preserved lung volume. If reticular pattern associated with reduced lung volume, you may think in fibrosis. But what about this? Can you comment?
Yes, so this is a frontal chest radiograph of a skeletally mature female patient. I can see a pigtail catheter in C2 in the that is projected over the left paracardiac location.
Good.
And there are reticular opacities seen in bilateral lungs with no specific zonal predominance. Few small cystic lucencies are also seen interposed between them. The lung volumes are relatively maintained, and there is blunting of the left CP angle.
Or even mild increase because some flattening of the diaphragm. This is important item to be mentioned. Very good. Okay, so
there is some there is blunting of the left CP angle, likely due to a pleural effusion or pleural thickening.
good.
There are no consolidation seen, and the rest of the there are no pertinent findings related to the mediastinum or the skeletal system. I would recommend further evaluation by CT. So in this, I can see that there are multiple cystic lesions seen in bilateral lungs with no specific zonal predominance. Small pneumothorax is seen on the left side, and there are no nodules that are seen. The lesions appear to be very well-defined oval of variable sizes. So my possibility in a female patient who is presenting with pleural effusion and pneumothorax would be lymphangioliomyomatosis as my primary differential. However, I would also like to correlate for any history of smoking, in which case Langerhans cell histiocytosis can also be a differential. However, the absence of any nodules and no cardiophrenic angle sparing would make that a lesser differential.
I am waiting for a certain point.
Right. I would immediately inform about this pneumothorax to the referring team, as it is an urgent finding.
Good. If not already managed. What else? You comment on the lung window only.
Right. I would also look at the mediastinal window images for any other findings.
Like what?
Like lymphadenopathy and any evidence of lymphangiectasia
What else?
and
Patient
case of
developed recently, in addition to the chronic chest symptoms, abdominal pain.
okay, so in patient with this abdominal pain could be due to some
Patient.
okay, so right, so there could be so there would be I would be expecting to see some angiomyolipomas in bilateral kidneys. So their bilateral kidneys are replaced by these heterogeneous fat density lesions.
So a mediastinal
Representing
window is very important to rule out the association, the common association, which is angiomyolipomas. We have here two emergencies. In the chest, pneumothorax, in the abdomen, hemorrhagic or rupture angiomyolipoma. Multiple angiomyolipomas, there is a possibility of a syndromic association. What it is?
tuberous sclerosis.
We have three emergencies in tuberous sclerosis. In the chest, pneumothorax; in the abdomen, rupture angiomyolipoma; in the brain, obstructive hydrocephalus. We may just remember safety conditions. You have to keep it in your mind, very solid. Okay. Any other friend want to share?
Yes, I can.
Okay, Abbas, proceed. We are in the same category. Let's describe.
I'm presented with radiograph chest frontal projection of an adult patient in which I can see that there are reticulations in both the lungs, predominantly in the upper, mid, and lower zones. I can also see that there is suggestion of subtle pneumothorax along the right chest wall. I cannot appreciate any pleural effusions, and the Hilar are normal. The cardiac outlines are also unremarkable, and bones are clear. I will immediately pick up the phone and inform the clinician regarding the right-sided pneumothorax, and also there is subcutaneous emphysema I can appreciate along the right chest wall, and there is a tubing which is visualized with its tip reaching up to the intercostal region of the upper area.
So if you see a pneumothorax only, it's okay. But if you see surgical emphysema, ask for zooming, because the chest tube is not accepted to be missed. Okay.
Right.
Pneumothorax is okay, but surgical emphysema must be iatrogenic cause. Okay,
Right.
I'll give you the CT scan, same case.
So I can see that the chest tube is in situ and there is a large subcutaneous emphysema along the right chest wall. I can see that there are multiple cysts in both the lungs. They are without any zonal predilection, and the lung volumes, they are preserved. I can also see that there is some intervening haze, but as I go down the CT angles, they are involved, but still relatively less
Really?
involved than the upper
Yes.
areas.
Relative sparing of the not absolute sparing, relative sparing of the lung bases and costophrenic angles,
And
as
so
compared to the predominance of upper lung lobes. Okay.
And
What
I
if a
can,
female patient?
sorry,
What if this patient is a female?
then I will
Same
keep,
diagnosis or different?
okay, in diagnosis, it will be
No,
lymphangiomatosis.
Same
Okay,
diagnosis.
okay.
Sparing of costophrenic angle, Langerhans. Okay. Yes.
Langerhans and
Male or
histiocytosis.
female? Male or, because smoking, male or female can smoke nowadays. Okay.
Yes, yes.
Few decades ago, males only, but currently male or female can smoke, and this disease is related to smoking. Okay. Okay, proceed. Another case, yeah, boss. I will make zoom to make it easier. Okay.
So I'm presented with the radiograph chest frontal projection of an adult patient in which I can see that there are tiny nodules along with the reticulations seen in the lungs, more on the right side.
and the reticulations are also asymmetrically more on the right. I'm looking at bilateral hilar area, which appear clear. The cardiac outlines are clean, and the CP angles are also acute. I'm looking for any pneumothorax. I cannot see that, but I can appreciate some of the stipples in the right axillary region.
Yes.
So
Surgical
for these
flips.
findings,
Yes.
surgical flips. So for reticulations and nodular reticulation shadowing, predominantly in the right lung and surgical flips, I'm thinking of the lymphangitis carcinomatosis due to any known primary. It could be a breast a lumpectomy with axillary clearance.
Very good.
Possibility of reticulations due to other causes could be a lung lesion, but I cannot find that. I cannot appreciate any bony lesion to suggest this lymphangitis due to any bone cause, and the thyroid area is also clear. My final diagnosis.
Another case.
I'm presented with the radiograph chest frontal projection of an adult patient in which I can see that there is relatively reduced lung volume on the right side.
Good.
And I can appreciate that there are reticulations in the right lung. The left lung volume is preserved. There is also raised right hemidiaphragm. I want to zoom in to look for some staples in the hilar region, as I can see some of the high densities there. Otherwise, I cannot appreciate any pneumothorax. I can see that there is deviation of the trachea towards the right side with soft tissue laxity noted in the superior mediastinal region.
Okay, maybe just a rotational effect, okay?
Okay, so reduced right lung volume with ipsilateral tracheal shift and reticulations. Yes, reticulations are seen. I'm looking at the these could be because of lymphangitis carcinomatosis, but I cannot appreciate any stipples here. I'm looking at the bones.
And the more important, in lymphangitis carcinomatosa, lung volume is preserved.
Yes.
What
but here the lung volume is reduced.
Yes.
So
volume loss and signs of volume loss.
Yes.
What is the cause of volume loss with reticulation?
It could be because of interstitial lung disease, but it is asymmetrical. So I'm thinking there may be a lung transplant on the opposite side, and the prior disease of interstitial lung disease is seen on the right side. So I will compare with the prior imaging if available. On basis of that, I conclude that there is lung transplant on the left side, which appears normal, and all prior reticulation changes due to interstitial lung disease are seen on the right side.
And you see here?
Yes, the ribs are widened, and there are changes of resection of the rib.
Widened the rib, most likely rib resection, secondary to lung transplantation. So whenever you see a thing like this, it's okay. Severe lung fibrosis in one side, or relatively normal on the other side, this is a lung transplant. Try to catch any findings here, like surgical clips on this side, on the normal side, and widened ribs, evidence of previous surgery. So unilateral reticulations with preserved lung volume, think of lymphangitis carcinomatosa. Unilateral reticulation with reduced lung volume, think of fibrosis with other lung transplantation. Unilateral reticulations with cardiomegaly, think of
Curly lines and pulmonary edema.
Yes, unilateral pulmonary edema. Most likely, either the patient lie on this side continuously, or the patient acutely with acute mitral regurg. It causes usually upper right pulmonary edema. I think this is another. I don't know if I listed here. Just a minute. Yes, here reticulation. I think I forgot to prepare it. No problem, no problem. Okay, so in case of reticular pattern, either reticular pattern with reduced lung volume in general, this is a fibrosis, or reticular pattern with preserved lung volume, this is actually a cystic lung disease. Bilateral symmetrical, but a reticular pattern unilateral, think of lymphangitis carcinomatosa, lung transplantation with lung fibrosis, or interstitial emphysema. Okay. Continue or no? Or enough? I am with you
Yes.
till tomorrow. Okay, it's okay.
Yes, we can continue.
Okay, okay. I will